Hi, everyone. I'm going to get started, and I've already let our speakers for this session know our task is to get back on time, so you have as much lunchtime as possible. So I'm just going to dive right in. Let me see if I can figure this out. So I'm going to talk, our session is going to be about combining immunotherapy with other treatment strategies. I'm very excited about this session. We all come at it from a different lens. I'll start from an organ-based perspective, and I'm going to talk about perioperative strategies, so immunotherapy and surgery. Let's see. So this is where we started before the advent of our new effective therapies. This is from AJCC7, which was still accurate in 2010. 15-year survival looked this, and it's broken down further for stage 3. But new therapies did come. I borrowed the slide from Tony Rivas. I always use it, and I'm very thankful to him because it looks cool. So we got checkpoint inhibitors, and we have a tool now to generate an immune response against cancer. In the stage 4 setting, this has improved survival for advanced unresectable melanoma. And it works when you stop treatment. And it has CNS penetration, all things that our prior treatments couldn't do for our patients. When then evaluated in someone who's had surgery to improve their recurrence-free survival, it's effective. And so what's worked in stage 4 works in the post-op setting. And it also works for resectable stage 4 disease. This is something not every histology does. In melanoma, if you resect a resectable stage 4 site, a distant metastatic site, giving checkpoint inhibitor therapy will improve your recurrence-free outcome. We've moved the needle further. This is very recent data. We're looking at relapses for node-negative disease, because in melanoma, actually, if it's quite deep, your relapses are similar to patients with stage 3 disease. And so same drug, anti-PD-1, single agent, compared to placebo for high-risk stage 2 disease. And also in this earlier disease, where in other diseases we have not given systemic therapy, we're seeing an improvement in their outcomes. But when is the best time to give this therapy? And I love that people have thought about this. I mean, the rationale here being, could it be better to give this systemic therapy prior to surgery? In breast cancer, other tumors, the idea may be if you shrink the tumor, the surgical outcome could be better. Maybe if you give systemic therapy earlier, your risk of distant metastasis goes down. So this is sort of time-related, local, regional, mechanics-related. But one thing that we really wanted to look at is it beneficial because you might prime the immune response better if you give the same treatment prior to surgery because the resident lymphocytes are still there. And as proof of concept, early signal finding studies were done at MD Anderson and UPenn, looking at just a single dose versus 2 doses of anti-PD-1 therapy prior to surgery, and then looking at their path response rates at time of surgery. And the response rates by RECIST and intraoperatively were very high, up to 80%, with just very little therapy. So really remarkable. Retrospectively, looking at aggregate cohorts with the International Melanoma Neoadjuvant Consortium, they also found that those patients who did have these good path response rates, they tended to be durable, and you'd had long-term good outcomes. And so people started looking at drug combinations to be given prior to surgery. And this is looking at Ipi-Nivo, just 2 doses ahead of surgery at a lower Ipi regimen. And indeed, the pathologic response rates are very high. So let's test it. This was presented last year at ESMO, comparing neoadjuvant versus adjuvant administration head-to-head. And the rationale here being, again, could the response to PD-1 blocking therapy be better because you have pre-existing anti-tumor T cells? On the right, you see an adjuvant approach that's done traditionally, which you have surgery first, you give the drug afterwards, and if there's micrometastatic disease, you're generating an anti-PD-1 response to that. That's always been the sort of rationale behind giving adjuvant systemic therapy of any kind, right, is to catch any micrometastatic disease that surgically is not captured. On the, sorry, that's on the left, excuse me, on the right, your right, you see the neoadjuvant approach. So if you give it prior to surgery, you're seeing, the tumor lumps in the axillary nodal bed is still there. Would you perhaps expand on, get a better expansion of tumor-resident lymphocytes that recognize the tumor better and get a better outcome? And so this is the schema, one-to-one randomization, and indeed, this did not get a standing ovation, but a lot of attention, which is a very remarkable 50% improvement in event-free survival between giving neoadjuvantly anti-PD-1 therapy versus adjuvant. So all you're doing is just shifting the same drug, the same regimen, 3 doses ahead of surgery, and this is the improvement. Just a few weeks ago at ESMO, the follow-up data on the path response and whether if you're getting path response, it is going to improve your recurrence outcome. And indeed, it does. You see the path response rates here further to the left, and they're actually quite comparable to combination regimens. And you see that actually a lot of, whether it's a partial, complete, or MPR, all of those actually lead to an improved RFS. What else can we do? Anything else? What about melanoma subtypes that have a higher tumor mutational burden? Everyone has seen this graph, I think, over the years. Tumors that have a higher tumor mutational burden have a better response rate to anti-PD-1 therapy. And in melanoma, we have a subtype called desmoplastic melanoma. And in the advanced stage setting, it was indeed found to have a higher response rate, up to 80%. And so here in the neoadjuvant setting, how would this population do? And indeed, we saw a really high rate of clinical responses to CRs. So this is the waterfall plot here. And so here, let me go back here. So here, just histologically, because the tumor is more responsive, you're getting an improvement on traditional response rate. Recently, at the ACR early this year, we saw that there's new antigen vaccine strategies that can be used. This is in the adjuvant setting. So here, rather than trying to stimulate an immune response by shifting the dose, you're giving a vaccination post-op. And this is actually the first improvement we've seen in the perioperative adjuvant post-op setting by administering treatment. Nothing previously had improved on PD-1 alone, and here you see a 40% improvement, albeit it's a randomized phase 2 and deserves further study and is now currently being evaluated in phase 3. Other neoadjuvant strategies, TVEC has been evaluated, which is an oncolytic virus strategy. And then to the right, you see Nivorella, which recently was found to be superior in the stage 4 setting, and that's also being evaluated now in the neoadjuvant setting. So, combinations, again, that work in the stage 4 setting, can we bring them into the neoadjuvant setting to improve on the immune response generated? If you're having all these effective systemic strategies, the next thought would be, well, what is the role of surgery then? If you can have durable long-term anti-tumor responses with systemic therapy, might you be able to downgrade some of the surgery? And so this is the Prado trial, which was sort of led by our European colleagues, looking at patients who've had a good path response rate to then omit a complete node dissection and to resect only the resident node. And that looked really positive. Other things that are on the horizon now, because we're having newer drug therapies, these are rapidly transitioning into the perioperative phase. And so in adjuvant therapy, we have 3 trials to look forward to for results. Relativity 098, which is the relatlimab and nivolumab combination in the adjuvant space, pembrolizumab and an anti-TIGIT, which showed promising investigational responses in the neoadjuvant setting. And then indeed, like I said, there's going to be a phase 3 activating very soon, looking at the Moderna neoantigen vaccine strategy. Also in the neoadjuvant setting, people are looking at utilizing this in an earlier stage disease space. And so here, this is by one of my colleagues, Georgios Karakoutsis from UPenn, in a single institution investigator-initiated study looking at pembrolizumab alone for 1 dose neoadjuvant for patients with high-risk T3b, T4, so node-negative neoadjuvant disease, node-negative presentations, and looking at sentinel node positivity rate as your proof of concept for histologic response. And so this would be very interesting. I mean, it's a patient population that's challenging. It's a very deep tumor. They're not bulky. They don't have bulky disease, but their relapse rates are very high. So take-home messages: effective systemic therapies in the advanced disease setting have improved perioperative outcomes. Also now in really earlier stages of disease, and so generating an immune response benefits patients at multiple sites of their journey. Neoadjuvant administration of immunotherapy is rapidly becoming a new standard of therapy as it enhances anti-tumor response, given better antigen presentation and stimulation of resident tumor lymphocytes, and results in improved outcomes. Newer combination therapies to enhance in either setting are moving forward. And I mean, with what we've just seen so far, the AJCC8, which came out in 2017, 2 years after perioperative therapies were approved, and 3 years from some of the more modern immune checkpoint inhibitors, already the outcomes by stage are significantly improved. The latest cancer report for the US in 2022 showed for the last 5 years, there's been a 4% decrease in melanoma death per year. And so this has been remarkable. Lung cancer, the same. The 2 histologies with the most rapid changes. Remaining questions are always there to answer. What's the optimal duration of perioperative adjuvant and neoadjuvant immunotherapy? Can surgery be further downgraded for those who've had past CR? And so trials are moving forward to consider omitting or waiting or holding off on surgery altogether if you're having a response. We all want better biomarkers, of course, to select patients who might benefit from perioperative therapy. Our German colleagues are looking at are conducting the Nivo-Mela trial, which is looking at a GEP signature to identify who might be higher risk and limit treatment just to those. And then, piggybacking on the last session, we want to better understand the long-term survivorship outcomes for patients for curable. We can now sit back and we don't want to rest on our laurels, but we want to improve outcomes for all patients. Thank you. I will now invite Dr. Reckamp up, who will discuss where this has gone for patients with lung cancer. Thank you.
Thank you. I appreciate the opportunity today, and it's exciting to be able to have maybe not quite as much, but almost as much data now in this setting as melanoma. So actually, these last few months have really accelerated the perioperative results that have been presented for lung cancer. So we will go through them. I will go through them quickly and hopefully get us a little bit more back on time. But again, so perioperative therapy. And so again, following closely behind melanoma, we got checkpoint inhibitors, which improved outcomes first in the second-line setting, very quickly after that in the first-line setting for non-small cell lung cancer, and then for small cell lung cancer. And then starting back in 2022 or late 2021, starting to understand in the operative setting as adjuvant therapy, neoadjuvant therapy, and now perioperative therapy, including both neoadjuvant and adjuvant therapy. So we have multiple uses. I think in the metastatic setting, one of the things we learned is that the earlier patients get PD-1, PD-L1 therapy, the better they do and the better outcomes they have. So really, this has moved for patients without targetable alterations. Immunotherapy has moved into the frontline setting. And again, giving it earlier in the perioperative setting also appears to be beneficial for most patients. We're not going to talk about targetable alterations today, and that may be an area where we need to really be testing ahead of time so that we're not causing harm to patients by giving them immunotherapy that for patients who might not need it or might not benefit from it. But that's probably a whole nother talk. So again, we've moved now immunotherapy from stage 4, stage 3 with the Pacific trial and durvalumab as consolidation therapy, and now moving it to the earlier stage settings. And we have approvals for adjuvant atezolizumab, neoadjuvant nivolumab with chemotherapy, adjuvant pembrolizumab, perioperative pembrolizumab, and then new phase 3 data presented for perioperative durvalumab and nivolumab. And so we're going to see some of this data. And again, we've talked about some of this, but again, neoadjuvant therapy gives us the earliest chance to try and attack micrometastatic disease, which has always been important to the medical oncologist. We definitely treat more patients and have more completion of treatment when we do it prior to surgery. We get information about pathologic complete responses and the response in the tumor, which may drive future decisions. And it may eliminate tumor cells that could be circulating after surgery by doing therapy prior. Adjuvant, again, probably the biggest advocates for adjuvant therapy is that we want to get to surgery early, and so adjuvant therapy provides the chance to get to surgery as quickly as possible. There are no pre-surgery complications to worry about. Longer duration for systemic control, because generally neoadjuvant we're doing just for a few cycles, which may not be enough for patients. And then some flexibility for patients following surgery. And again, the first data we have with immunotherapy in the perioperative setting is really in the adjuvant setting. And the Empower 010 study showed us that atezolizumab could improve event-free survival. And this was a little bit complicated in the statistical analysis, but they did it by PD-L1 and by stage. And so the approval is in stage 2 to 3A with PD-L1 greater than or equal to 1%, and was not approved for those with less than 1%. And you can see on the right-hand side the subtleties of the hazard ratios. And again, greater than 1%, the hazard ratio 0.66, whereas less than 1%, the hazard ratio crossed 1. And so we have an approval, and we have some. We'll look at some of the survival data too, which is still early. And then the Keynote 091, or the PEARL study, was presented subsequently to the Empower study. And here, there was an improvement in event-free survival for all comers. And importantly, the PD-L1 didn't make a difference in outcomes. And so now we have an approval for pembrolizumab for all comers, for patients with stage 2 or stage 3 non-small cell lung cancer. And again, this is still early, and median follow-up is still in less than 4 years, but we don't see significant changes in overall survival in these patients, though we do see disease-free survival benefits for these patients. So what about neoadjuvant immunotherapy. And this is really where the field is going. And I think we've learned from melanoma and breast cancer and other diseases how well this can help our patients. And immunotherapy in the neoadjuvant setting, again, we get the treatment with the immune checkpoint inhibitor early when the tumor is still in place. So we activate a diverse set of T cells to the tumor that is actually still in place. So those tumor cells those T cells may be more active and more immune primed for those tumor cells. We get the surgical resection, and we still may have some systemic anti-tumor immune response still benefiting patients. So the first was the Checkmate 816 trial, and that was just neoadjuvant nivolumab and chemotherapy versus chemotherapy alone. And this was presented last year. And again, improvement in event-free survival for patients who receive the nivolumab and chemotherapy, with at 2 years, more than 60% still event-free. And again, the overall survival here, this is not quite meeting statistical significance, but again, still early, less than 4-year follow-up, but still we see significant survival benefit, or we see, not significant, but we see a trend toward survival benefit here. So we're seeing that, and I'm not showing all of the data because there's just way too much data on pathologic complete response and things like that. I'm going to go into some of that data with the newer studies, but there were improved in pathologic complete responses and improvement in potentially more patients getting lobectomies and potentially lesser surgeries without patients who did not go to surgery because of complications. So patients were still able to go to surgery and potentially have lesser surgeries. But again, another topic for another day. So then we had coming out of, so ESMO was a very robust meeting for the perioperative setting. So the keynote 671 was first presented at ASCO this year. And then the overall survival data was presented at ESMO. And again, so this is perioperative. So now we're talking about the neoadjuvant, chemotherapy and immunotherapy, followed by surgery, followed by adjuvant. So now we're combining the two approaches. And I think one thing that is striking when we look at these, when we look at patient characteristics, is by far our surgeons are choosing who to send. So 2/3 of the patients are stage 3. And so though these are approved in stage 2 and stage 3, the majority of patients who go on these trials are stage 3. And so still our surgeons are choosing those patients. When you look at the adjuvant study, like the Empower 010, we see far more earlier stage patients. And so, teasing that out and understanding who's benefiting best is still important. So again, event-free, so this was presented, this is the presentation from ASCO, but we have a significant improvement in event-free survival and a trend toward improvement in overall survival with the 25-month follow-up. And the NeoTorch study seen on the right-hand side was also presented as a neoadjuvant followed by adjuvant immunotherapy trial, which had, again, a trend toward improved overall survival, and this was only for stage 3 patients. And then again at ESMO this year, the overall survival presented with a significant hazard ratio of 0.72, still relatively early, but we're starting to see, again, this now getting statistical significance. So this is the first trial to show statistically significant improvement in overall survival for the neoadjuvant followed by adjuvant immunotherapy. And when you look at the subgroups, pretty much across the board, we see benefits in all the subgroups. The never smokers, very small cohort of patients, only 50 patients, but they're, again, as we might expect, they didn't have the same robust benefit and cross the 1 mark. They had about 15 patients with EGFR, and there's a huge confidence interval for those. But again, we have other treatments, including adjuvant osimertinib for those patients. So across, and then by PD-L1 status, again, trending toward lesser benefit in the less than 1%, but still benefiting across the board. And so this is got approval just last month for all patients with non-small cell lung cancer, with resectable non-small cell lung cancer. And again, they represented the event-free survival now with 48 months, and about 50% will be disease-free at at 4 years, which is, and again, knowing that 2/3 of these patients were stage 3 patients, pretty unheard of in the lung cancer era. So, and then we go to Aegean, and this is, again, neoadjuvant durvalumab and chemo, followed by adjuvant durvalumab after surgery. Again, 2/3 of the patients with stage 3 disease, pretty equal across PD-L1 subsets. This was also presented, the event-free survival was presented at AACR earlier this year, and again, at 2 years, 63% event-free with significant improvement. And then they presented a little more data at ESMO, and now looking at circulating tumor DNA. And so this goes to where we have to go with this data and who to treat and how long to treat, as we discussed for melanoma. But what you see here on the left-hand side are circulating DNA, and the far left is the durvalumab versus placebo, and significant drop in the circulating DNA compared to those who got chemotherapy and those who got durvalumab. And then you look here on the right-hand side, the full clearance was significantly higher, and again, 2/3 of patients with clearance versus less than half of patients with chemotherapy alone. So we are clearing disease. This is kind of more of the same, but this is looking at DNA clearance by pathologic or complete response or major pathologic response, and again, showing that durvalumab does improve those patients' DNA clearance in those who even get the pathologic complete response. So it may be a marker that we can use to understand who needs more treatment. The next study that was presented at ESMO was Checkmate 77T. This has the least follow-up so far, very similar patient characteristics, nivolumab, chemo, followed by surgery, followed by nivolumab. And again, improvement in event-free survival, 70% at 18 months, again, with shorter follow-up here. Most subgroups with showing improvement, maybe a little bit less for PD-L1 low. And they also showed by disease stage, and again, the stage 3 in this group had much more improvement, and then again, the PD-L1 greater than 1%, whereas the stage 2 had less significant improvement in some crossover of the curves. The pathologic complete response was increased, and major pathologic response was increased. And this is similar across these trials. We see kind of 25% pathologic complete response versus 5% plus or minus for the chemotherapy arm. So these are pretty consistent results. So we know that these trials are showing benefit. We have multiple trials now with the neoadjuvant followed by adjuvant therapy. And again, each of them are a little bit different, but overall, again, majority are stage 3 patients, and most of them have very few if they included patients with EGFR, ALK, or other alterations. So we're seeing improvement. And we know that we can improve outcomes, again, with neoadjuvant followed by surgery, surgery followed by adjuvant, and now all of these perioperative studies that are also coming back as positive. So we have multiple choices for our patients, and none of these have been compared to each other. So what do we need to do next? And I think the cooperative groups are trying to work on this question. This is probably not a question that we can get other groups to answer, but and the other question that's out there is, so in lung cancer, it's always we bring a patient to tumor board and decide if they're resectable, and then we decide on the therapy. But like in breast cancer, we can make patients resectable, right? So can we make more patients resectable? We certainly, from some of the data and the surgical outcomes, we can make more patients go to lobectomy, which we know is safer and have better outcomes for patients. So I think that's a question that's lingering in the background. And can you make a patient who's stage 3B who would go to chemoradiation and make them a potentially resectable patient? All these questions are out there. So again, some suggestions about how to give the therapy, whether to just give neoadjuvant, whether to just give adjuvant. And again, pathologic complete responses do matter. And so how do we determine who those patients are going to be? And again, by the Checkmate 7T, again, patients with pathologic complete responses, no matter what therapy they got, did better. And so how can we determine pathologic complete response? Maybe ctDNA or minimal residual disease. And again, some of these patients may not need further immunotherapy. We may overtreat these patients. Some of these patients may not need surgery. well, that's a question that we would, I mean, be afraid to ask, I think. I mean, in melanoma, it's a little easier, but in lung cancer, who would even guess that? But we did have a patient recently who went to surgery, and there was no tumor. And the patient was furious that he went to surgery. But we were happy, but he was not. So anyway, so there's a lot of questions, and I think a lot of trials that could come from this, but they have to be willing to ask some questions that are about sequencing and about timing and about the right patients, and potentially even limiting therapy for patients who may do exceedingly well and may be cured with the upfront therapy. And we're looking for biomarkers, and then the bottom line is that we now have also good data for event-free survival for alectinib in the adjuvant setting from the ALINA trial presented at ESMO. And so for patients with targetable alterations, neoadjuvant followed by adjuvant immunotherapy may not be the best treatments. And so we really do need to start testing for biomarkers even before surgery, before neoadjuvant therapy, so we're not giving immunotherapy to those who don't benefit. But I appreciate your time and welcome any questions as we move on to the next speaker. Mm-hmm. Thank you.
Yeah, we'll take all your questions at the end of the session. Thank you, Dr. Reckamp. That was really an amazing overview. I'm excited. Dr. Monjazeb, am I saying it right? From UC Davis is here, and he'll talk to us about radiation and immunotherapy. Thank you.
Thank you so much for having me here, and these are my disclosures. So this is just an overview of what we're going to try to discuss today. 15 minutes is not really enough for this topic, or at least I have to say that, because this is what I study, and if you say, I can summarize everything I study in 15 minutes, then it makes you seem like you're not really studying that much. So, but we're going to talk a little bit about just kind of the basics of radiation immune modulation. So why do we think that radiation might be a good partner for immunotherapy, and then look at some of the data that's there in terms of combining radiation with immune checkpoint inhibitors, and then in terms of other potential combinations. So the basic idea is that radiation can cause an in situ vaccine effect. And there's actually quite a bit of data to suggest this, both preclinical and clinical. And radiation has a diverse effect of immune modulatory outcomes. It can alter the vasculature, making tumors more permeable to immune cells, release chemokines, changes in the endothelium that can help immune cells infiltrate into tumors. It can change the tumor cells themselves. It can increase MHC expression, stress ligands, things like this on the tumors, making them more prone to killing by immune cells. And it can cause a release in a number of different cytokines. And as well, in addition to that, radiation can also cause a release of something that we call DAMPs, which are called damage-associated molecular patterns. And these are basically ways that the immune system decides what program to go down. And what we find is that radiation probably induces a program that's fairly similar to a viral infection. So when we irradiate a tumor, the immune response almost gets the same signals that it would get if there was a viral infection happening in that location. And so the idea is that in an idealized version where kind of pre-radiotherapy you may have a very suppressive immune microenvironment, that post-radiotherapy we magically change macrophage polarization, we cause maturation of our antigen-presenting cells, we increase activation of our T cells, et cetera. And this here is just a selected list of some of the immune modulatory effects of radiation therapy with some of the references there. But really, you can see that the effects are quite diverse. But it all really revolves around inflammation. And so because of these various effects, we do think that radiation should be able to partner well with immunotherapy. And this is just some data from our own lab that I haven't included in this list here. And there's been a recent, I think, interest in looking at natural killer cells in solid tumors. And what we published in 2 papers back in 2016 was that we actually see that radiation, maybe even more so than the positive effects it can have on T-cell immunity, can actually have quite an effect on natural killer cell immunity in solid tumors. So we see that it can release chemokines that actually attract natural killer cells. But in addition to that, we know that radiation can upregulate MHC molecules, but it can also actually upregulate stress ligands on cells. So the cells that aren't killed by radiation are stressed by the radiation, and so they will upregulate stress ligands. And this is actually one of the things that natural killer cells recognize to kill damaged cells. So there's an expanding body of data looking at this as well. But I think the key point is that the immune system is not in the business of unchecked inflammation, right? The immune system is in the business of maintaining homeostasis, as are all our physiologic systems. So if you have overreactivity of the immune system, you get chronic inflammation, autoimmune disease, bad things. And if you don't have enough activation of the immune system, then you can get things like tolerance to cancer, being prone to infections, and these types of things. So because of this, the immune system is really very tightly regulated. And the inflammation that radiation causes comes at a cost. And so this is from a cohort of sarcoma patients treated at UC Davis. And what we see is that post-radiation, we do see the changes that we've talked about. So this is just looking at T cells and B cell infiltrate into the tumor microenvironment. And we see that pre-radiation compared to post-radiation, there's a significant increase. And this is with fractionated standard radiation. We think that this effect is actually even more pronounced if we use ablative or hypofractionated radiation. But additionally, what we see is we see an upregulation of immunosuppressive factors. And I think the point here is that the acute inflammation that's caused by radiation and that cell stress, I think, is very productive in terms of inducing an anti-tumor immune response or expanding an anti-tumor immune response. But eventually that will lead to chronic inflammation, which will lead to immune suppression. Because again, the immune system wants to, within a matter of weeks to months, to clear an infection and then to go back to its baseline state. And when that doesn't happen, that's when problems occur. And really with cancer, rarely do we see that happen. So when we're thinking about the immune modulatory effects of radiation, then I think it's very important for us to think about the kinetics of it. So there may be this window of opportunity where we have these pro-inflammatory effects before the negative effects of chronic inflammation set in. But that also the dose and fractionation of radiation is very important. There's a good amount of data now suggesting that low doses of radiation, what we would even call kind of sublethal doses, doses that aren't even enough to kill tumor cells, can be enough to alter the vasculature and the endothelium and increase the homing of T cells. Also, those low doses may be high enough to actually alter the macrophage polarization within the tumor microenvironment, but higher doses may be needed in order to induce release of interferons or cause immunogenic cell death, things like this. So I think really when we're thinking about radiation, we shouldn't think about it as a single treatment. We should think about it as many different drugs with pleomorphic effects, and depending on how you use it, those effects can be quite different. Even the tissue that's being irradiated is important. So we published a study a few years back looking at ablative radiation therapy, and what we found was that if we ablate the bone, the immunologic effects that we get systemically are much different than if we ablate the lung. And that's much different than if we ablate the liver or the brain. So I think even the tissue and the tumor type that's being irradiated is important. So there's still a lot of learning that needs to occur here in order for us to understand how best to use radiation. So in terms of combining radiation with immune checkpoint inhibitors, this is a field that really, I think, exploded early in the checkpoint inhibitor revolution with this publication from Sloan Kettering that showed that radiation can induce ICI responses in patients who were resistant. But since then, we've obviously had other data that suggests that radiation can partner well with immunotherapy. So there's the Pacific trial, which showed a benefit. And then more recently, this is some work from our group at UC Davis looking at moving radiation even earlier into the lung cancer stage, looking at patients who have stage 1, 2 medically inoperable non-small cell lung cancer. And based on this work, there's actually now the SWOG NRG S1914 trial, which I'll make a little plug for, so please accrue patience to that trial. But basically what we found was that this was for the phase 1 portion, we did the dose escalation, and what we found was that patients who were treated at suboptimal doses had high rates of systemic recurrence. And again, we chose a patient population with larger tumors, high PET activity, that we would expect about a 50% systemic recurrence rate in these patients who are medically inoperable and generally considered to be unfit for systemic chemotherapy. But once we got up to full dose atezo, we didn't see any failures. And we were also able to see that patients who didn't progress seemed to have a much higher, not just T-cell infiltrate, but T-cell activation if we're looking at both proliferation and killing activity by granzyme B within the tumor microenvironment. Additionally, another trial that kind of supports this idea of combining ablative radiation therapy in lung cancer was recently published in Lancet, and this was a phase 2 randomized trial of 141 patients, and they found that the addition of Nivo improved the 4-year event-free survival from 53% to 77% compared to just SBRT alone. Now, I think the key thing from all of these trials, however, is that they show that radiation, or excuse me, they show that immunotherapy can add to radiation, but they don't necessarily show that radiation can add to immunotherapy. And I think, the data there is still lacking, but there is some hints from the Pacific trial. So if you look at the initial publication of the Pacific trial, there is this data that's kind of in the supplementary figures, which to me is informative in that it tells us that patients who had their immunotherapy initiated closer to the finish of radiation, so again, this idea of this window period, seem to fare better than patients who did not. So this is in the supplementary materials, and I think, hasn't been given enough attention, but I think it's actually, to me, pretty interesting data suggesting that there is this kind of temporal relationship when you're combining chemoradiation with immunotherapy in terms of having things timed correctly. But ultimately, I think in terms of combining radiation with immune checkpoint inhibitors, I think that the jury is still out, because I've shown you positive trials, but the truth is that we've done hundreds of trials, and most of them have been equivocal or negative. 2 trials that I've listed here are trials that were led by myself that were negative in terms of combining radiation with dual checkpoint inhibitors in non-small cell lung cancer or in colorectal cancer. So I definitely can tell you from firsthand experience that it's not universal that radiation and immune checkpoint inhibitors can be combined. And I think that most of our trials have been negative, but our best successes have definitely been in lung cancer. And the way that I think about this is we want radiation to create this in situ vaccine effect. But the truth is that if radiation was an excellent in situ vaccine, we would see abscopal effects from radiation alone much more often than we do. But the truth is that it's a very rare occurrence. And so my thought process of this is that maybe we're asking the radiation to do too much, right? There's very few vaccines that can work without an adjuvant. So I think that the radiation likewise probably also needs an adjuvant. So in terms of other combinations of radiation and immunotherapy, there's just a general breakdown. You could combine radiation with vaccine approaches, and there's certainly data that radiation can increase clonal diversity and clonal expansion. You could combine radiation with adoptive cell transfers. Sorry, this is not, it's kind of jumping all over the place, so let's see. There we go. Certainly we've shown that radiation can upregulate MHC, it can upregulate stress ligands, it can make cells more prone to fast ligand killing, but also can increase the infiltrate of CAR T cells into the tumor microenvironment. I've already gone over the data with checkpoint inhibitors, but for me the most interesting part is really combining radiation with immunostimulatory therapies. And I think this is particularly important if we want to then combine that with immune checkpoint inhibitors, because I think to really get a robust in situ vaccine effect where you can then get your immune checkpoint inhibitors to work in quote-unquote immune cold tumors, I don't think radiation alone is enough. I think radiation needs to be partnered with immunostimulatory treatments. So I'm just going to show you a little bit of data to wrap up about that. So I think some of the best data for immune effects of radiation comes in this field. So this is work out of the Earl Childs Research Institute up in Portland, where they combined radiation, ablative radiation, with high-dose systemic IL-2. And what they found was an objective response rate of 66% compared to historical controls of 10 to 15%, so super impressive. Their phase 2 comparative trial was a little bit less impressive, but they still definitely saw more responses in patients who received radiation plus high-dose IL-2 compared to high-dose IL-2 alone. However, the difference in this trial was that this became kind of after the checkpoint era, so most of these patients were patients who had already failed checkpoint inhibitors, so it makes that interpretation, I think, a little bit more difficult. This is data from Dr. Levy's lab, or Dr. Levy's group in Stanford, where they were combining TLR9 agonists with radiation for lymphomas. And my lab basically expanded this work and added in an additional immunotherapy, an IDO inhibitor, based on some of the nuances we were seeing in their data. And I just want to kind of point this out as an example of maybe of how we can best combine radiation with immunotherapy. So what we were able to find was that this, the CpG, or the TLR9 agonist, which acts as like a vaccine adjuvant, was able to really induce robust immune responses, and we saw this in mice, but we also, being UC Davis, tested this in dogs at our vet school, so people's pets, and were able to see robust immune responses. And so we decided to take this forward into a human trial because UC Davis also has human patients. And what we were able to see in this early stage trial was actually pretty impressive results for a phase 1 trial in heavily pretreated patients, where we were able to see a pretty good response rate with this approach. And when you're looking at this swimmer's plot, the patients who are highlighted in red are patients who had failed prior checkpoint inhibitor therapy. So it tells us that maybe there is something to kind of combining radiation with immune stimulatory agents in order to be able to induce a response in patients who are resistant to immune checkpoint inhibitors. And on the right, there's just an example of left panel, right panel, pre and post treatment for patients who had, the 2 patients who had a complete response. So I'll go ahead and stop there. Thank you.
Thank you very much. That was a really amazing overview and of very interesting work here. I have the pleasure to introduce Dr. Tanya Dorff now. She's the GU section chief of City of Hope, and she'll talk to us about combining immunotherapy with other drug therapies. Thank you.
Thank you so much for the invitation to be here. These are my disclosures. So much of what I'm going to discuss is really RCC and urothelial cancer, because that's where a lot of the combinatorial strategies have played out with immune checkpoint inhibitors, largely together with a couple different classes of drugs that we'll address. But prostate cancer being my first love, there will be a little interspersing of prostate cancer as well. So back when I started as a fellow, we didn't have any treatments for kidney cancer. So it was really groundbreaking when the VEGF TKIs came around, sunitinib, sorafenib, and they were just profoundly more effective than anything we had seen before. I mean, we had interferon alpha and high-dose IL-2, but these VEGF TKIs were also very, very powerful agents. And then as second-line therapy, we started to see activity of immune checkpoint inhibitors, primarily nivolumab. So then the question became, should we combine these? And you'll see on the right that both combinations of IO-IO with Ipi-Nivo were successful at besting sunitinib in the first-line metastatic RCC setting, although favorable risk actually did really well with the sunitinib. And then the IO-TKI combinations, which you can see there are multiple. There's Axi-Pembro, Cabo-Nivo, lenvatinib, and Pembro. So there's just multiple combinations. And these all also bested sunitinib. Poor sunitinib was always the comparator in the first-line metastatic renal cell setting. So was this a case of Reese's peanut butter cups, like chocolate and peanut butter are both good? Are they good together? Or was there a rationale for combining these as the next step in therapeutics? As it turns out, VEGF inhibition has some interesting changes on the tumor immune microenvironment beyond just perhaps normalization of tumor vasculature, which is something we think about VEGF inhibition being able to do. It actually has these, VEGF has inhibitory effects on certain populations of immune cells, both directly and indirectly, so that when we expose a tumor to VEGF inhibition, we actually see better dendritic cell function and less immune suppressive components like MDSC and Tregs. So there was good reason to combine these two classes of drugs together. So the big debate at ASCO this year, I don't know if anyone was in the room for the GU sessions, but there were heated discussions because we don't yet have a trial of TKI-IO versus IO-IO. And so everyone still has their favorite. So this is borrowed from the discussant at ASCO, just putting up the survival curves for a couple of the combination trials on the left, Keynote 426 with Pembro-Axi and the Pembro-Lenvatinib trial on the bottom left, comparing to Checkmate 214 Ipi-Nivo. So again, we've never had a head-to-head comparison. I think all of these curves look good. But there's the point being made that IO-IO perhaps has a better tail on the survival curve. So the other question, though, is with sequencing. Once you use a TKI-IO, what do you go to next? We do have other combinations, but IO-IO still leaves room for the TKI. It also avoids or delays the time until those daily oral TKI kinds of side effects. But really, you get that nice dramatic initial response with the TKI-IO combination. So you can make an argument either way. And so there weren't really new data at ASCO. It was really just a lot more of hearing different people's perspectives. So these are the Cabo-Nivo data. And just to point out the side effects, interestingly, that combination doesn't seem to add too much above and beyond the TKI itself. There are overlapping toxicities, so there can be some challenges with understanding is the diarrhea from the TKI or from the IO. But there have been some very nice presentations over the last few years helping us to understand strategies when we get what looks like an overlapping toxicity of how to approach it systematically so that we can figure out which drug needs to be modified and continue patients on therapy. So Cabo-Nivo, I think you'll all agree, the survival curves look very nice here. But at City of Hope, we're actually interested in always doing even better. And one of our areas of interest has been in manipulating the microbiome. So we know not only from genitourinary cancers, but other cancers, that when we alter the gut microbiome, we can enhance the responsiveness to immune checkpoint inhibitor therapy. So Monty Powell, my esteemed colleague, had run a trial of Ipi-Nivo with this prebiotic CBM588 that was published in Nature Medicine. Really a small study, proof of principle, and just showed that you could shift the gut microbiome. And so he has a follow-up study that was presented by one of our international fellows, Dr. Ibrahimi, this year at ASCO with Cabo-Nivo and CBM588. And you can see on the right-hand side, those orange and blue boxes are actually the primary endpoint. This was a very small study, like around 20 to 30 patients. And again, the endpoint was a microbiome endpoint. Did we shift it with the CBM588? But despite these very small numbers on the left, I think you'll see it's quite striking that the progression-free survival is markedly better in the patients with the prebiotic. And the response rates, if you look at the candy corn-colored graphs on the bottom there, much more active responses with this prebiotic. And so SWOG is actually going to take this now into a phase 3 trial, potentially building on these really exciting preliminary data. So I told you there would be prostate. We've been, sort of an immune desert other than Sipuleucel T, but we're finally potentially going to have immune checkpoint inhibitor in an active combination in prostate. So this was presented by Niraj Agarwal some time ago. This was from a big phase 1 of cabo plus atezo in various tumor types, looking at the mCRPC patients. Notably, these are not bone met patients. These patients all had to have visceral or large soft tissue metastases. So this is not every prostate cancer patient. Unfortunately, it's probably 15 or 20%. But you can see a pretty substantial waterfall plot, much better than what we had ever seen with immune checkpoint inhibitors alone. And so cabozantinib, which had also gone all the way to phase 3, actually, in prostate cancer and showed some efficacy, but not this degree of efficacy, together with immune checkpoint, seems to be modulating the tumor immune microenvironment in ways that allow us to now see true activity. And we've actually seen the press release of the phase 3, cabo-atezo, versus a second AR pathway inhibitor in mCRPC, again, selected for visceral and soft tissue. We know that that trial is positive. We just haven't seen the data yet. Hopefully we'll see them next year, but this may become an option. All right, shifting to urothelial cancer and the ADCC IO combinations. So again, back when I was a fellow, we sort of thought that cisplatin was the gold standard, could never be unseated for urothelial cancer. We actually had some durable remissions, and it had remained in the first-line setting for a very long time. IOs added to chemo didn't seem to work out so well, although we'll look at the new data from ESMO. But there was switch maintenance data. So after induction, if you had stable disease or response, then you could go on to an immune checkpoint, and that did improve outcomes. Otherwise, you use second-line immune checkpoint. And then beyond that, we had the ADCs showing up, EV and SASCG, as well as an FGFR inhibitor for patients with an alteration in that pathway. So at ESMO this year, everything was upended by 2 major presentations, the first of which was EV-302. So what is EV? Enfortumab vedotin, this is an antibody-drug conjugate. The antibody is Nectin-4, which is very highly expressed in urothelial cancer and other cancers. And the cytotoxic payload is MMAE, which is a microtubule inhibitor. So this has shown strong activity in urothelial cancer in sort of the second, third line setting, and now added to pembrolizumab is showing even more activity. So this is a very busy slide. I'm grateful to Andrea Paulo, who was the discussant at ESMO for these 2 major trials, Checkmate 901 and EV-302. But what she's trying to show here is that previously we did have chemo plus IO trials, like what we saw in lung cancer, but they were negative until Checkmate 901. Now, Checkmate 901 has this third arm of ipi-nivo that is not yet reported out. What was reported was the gem-cis nivo versus gem-cis, and it was positive. So this was our first combination trial with chemo and immune checkpoints that was positive. But the bigger splash even is the EV-302, which is enfortumab vedotin plus pembrolizumab versus chemo, showing clear superiority for the ADCC IO combination. So one question was, why was Checkmate 901 positive when all those other trials had been negative? And they think cisplatin could be the secret sauce. All the other trials did allow for carboplatin and cisplatin ineligible. So I don't know too much about why cisplatin might be more immune activating, but there was a lot of discussion about that. When we look at EV-Pembro, you can just see, compared to the 901 on the left, even more striking superiority. I mean, the median overall survival for the cis-gem-nivo of 21.7 months is fantastic. We've never seen survivals like that in metastatic bladder cancer. But to get 31.5 months with the EV-Pembro is truly remarkable. Hazard ratio of 0.47. I mean, these are exceptionally strong data. And we had seen in the neoadjuvant setting that EV-Pembro was a powerful combination. But these were really gratifying data. Got a standing ovation at ESMO. I mean, people really feel like this is going to change the lives of bladder cancer patients. So why the ADCC works? MMAE is a microtubule inhibitor. There is thinking that this has some immune activating or immune modulatory aspects when it's killing cancer. Although, it would be nice to see other ADCCs, since this does have quite a bit of toxicity from the MMAE component. There's a new ADCC being developed for bladder cancer targeting HER2 that has an MMAE payload. You can see beautiful waterfall plot when it's combined with an immune checkpoint inhibitor. Maybe it is this MMAE payload that is driving this phenomenal responsiveness of the combination. But as I said, the toxicity is daunting, and I think one thing we don't hear enough in the presentations of the data is how did people actually get their patients on these drugs? One of my patients on EV-302, I inherited him. When I first met him, his daughter said, "What have you done to my father? Like, he used to go dancing and now he's in a wheelchair." And they had just continued the EV too long, right? We don't know how much you need, but we do know that people need breaks, they need dose reductions. And at some point, we just stopped, well, as soon as I met him, we stopped his EV and just continued the Pembro, and he stayed in a complete response for another 1.5 years now. So that's going to be the next leg of work, is figuring out how much, is this like an induction and maintenance phenomenon, or how much of the combination do you need before you can switch to immune checkpoint alone? And maybe with sacituzumab, for people who do have neuropathy, we'll have an alternate option for ADCC IO. There are studies, that have reported out that look pretty good, because this does have a lot of peripheral neuropathy, and it can be motor as well as sensory. So in prostate, again, my favorite, we don't have ADCC per se, but I think radioligand therapy sort of counts as an ADCC. It's an antibody with a radioactive payload instead of a cytotoxic payload. So I added it to the talk. And based on the last presentation, there's a lot of interest in combining radiation with immunotherapy, and radioligands are a whole new world to explore, because here we're delivering the radiation through the bloodstream to all the tumors, rather than depending on radiating one or two and then inducing that abscopal effect. So there have been a couple early presentations of combinations of radioligand therapy with immune checkpoint inhibitors. They're all single arm, so we can't really make any conclusions about what one is adding to the other and which one is driving the responses. But you can see in this case with pembrolizumab and the actinium-225J591, which targets PSMA, really nice waterfall plot, probably more than we see with the radioligand, certainly more than what we see with pembro alone, which doesn't really work very well in prostate cancer. And then we also saw the PRINCE study, which was the lutetium PSMA together with pembro. So more to come. We have all these different combinations, but as always, with more answers come more questions, so stay tuned. Thank you.
Well, thank you, Dr. Dorff. That was really indeed exciting. I remember the standing ovation. So much has happened in the GU space. I want to invite all the speakers from the session to come up. We're going to do a Q&A now. Dr. Iqbal, unfortunately, is ill and could not join us today. And yeah, if you have any questions, please send them through the chat, and we'll get to them. There's a microphone somewhere also. So if you want to ask live, don't be shy. Well, thank you, everyone. I was excited when we thought about the sessions and that you guys would be speakers for these topics, because I think all of us want to improve immunotherapy, and there's all these different ways to do it. And I definitely saw different themes to here. I'll start with the first question, which is directed to Dr. Monjazeb, which is, long ago the abscopal effect at one point referred to negative effect because lymphocytes are flowing through the field. And does that now apply now when we are using smaller ports, thus getting more positive synergy than before?
Yeah, so I think that's a very good question. So undoubtedly, most of the immunosuppressive effects of radiation are probably due to the blood pool being irradiated. And so when you're doing fractionated radiation with large fields, there's studies that show a large portion of the lymphocytes are being irradiated, and you can get drops in lymphocyte count. What that means for immunotherapy, I think, is not quite known yet. Probably the more important issue is actually the irradiation of the draining lymph nodes, and whether that's, certainly we don't want to have patients recurring in draining lymph node regions, but at the same time, when combining with immunotherapy, is that something that's negative? I think there's a lot of work going on with that, but I think either way, these more focused ablative treatment approaches definitely address both of those, because generally you're not irradiating the draining lymph nodes, and usually with your tighter margins and a fewer number of treatments, you're irradiating less of the blood pool.
I have a question for Dr. Dorff, and I'd love it if Dr. Reckamp also has thoughts. That'd be very welcome. Thinking about targeted therapy when it's combined with immunotherapy, there's a lot of persuasive mechanisms of actions that happen. But like in real life, in the clinical trials, it's a little bit mixed. And I saw you also compared it to IO. And I know like in lung cancer, we think that why isn't it synergistic? So I would love to hear your thought why you think sometimes it works. Is it because separately they work well together already, and so then you put them together, it's synergistic? Are there other things in the microenvironment you think are affecting this? Thanks for your thoughts.
Yeah, so that's a very important question. But I think it has to be more than just killing cancer cells, at least in prostate. It may be different in other cancers, but that's part of maybe why the chemo plus IO took longer to yield results, and they're good, but they're not quite as striking. So I think we need something else to be happening. And for all of the work we're doing in combination strategies, it's really coming down to how is it modifying the macrophages, the MDSC, the Tregs. And I think that preclinical work is so important. We have infinite possibilities for combinations, and we really want to approach it rationally. So dendritic cell function, I think, is often overlooked, but treatments that can improve, antigen presentation by various mechanisms will also ensure that once T cells get into the environment, they can do what they need to do.
So I would agree with finding rational approaches, because we have so many drugs and we just start to combine them. And so I think lung cancer is a place where we can learn a lot. And so the chemoimmunotherapy, that's kind of something that we all agree works really well, at least in lung cancer. And but where we've had struggles is combining immunotherapy with targeted therapy. And if you look at the targets, things like EGFR and ALK, generally we see more toxicity. And we have these drugs that have 80 to 90% response rates, and then we cause grade 3 toxicity in many cases. And so some of those trials were stopped early. It's often, for osimertinib, it was ILD. For others, it have been liver toxicity. The KRAS inhibitors have been a challenge with liver toxicity. And so we're having a challenge with toxicity, so you take a good drug and you potentially have to stop it because of the immunotherapy. So that's one issue, but I think the other area is VEGF. So in multiple tumor types, we see both VEGF TKIs and antibodies very effective in liver cancer, renal cell, and so we see these benefits. And in lung cancer, we have 3 trials in the past year with VEGF TKIs showing lack of benefit over docetaxel, which is a pretty low bar. It appears that toxicity may be part of that too. And so that's something we need to learn from. So if we're increasing toxicity and patients can't stay on it, they may not get that benefit. And then again, the trial that we did through SWOG in the lung map was with ramucirumab and pembrolizumab, which showed an overall survival benefit. So there may be differences with the antibodies versus the TKIs, but I think at least in lung cancer, the TKI combinations, toxicity has been an issue.
Yeah, I find it so interesting. In melanoma, we've also, experimented with TKI combinations. We have a BRAF inhibitor similar to EGFR inhibitors that's very, very active. And, we have some good preclinical models, and then it just doesn't quite work out. And I think the other part that we don't always see with an IO combination that's difficult to explain is, we all want that tail of the curve, And so
we had a lenvatinib combination, which looked very active at the beginning, and then at the tail, it just didn't quite work out. And it's just, which is interesting, well, I want to thank you, faculty here. This is a really interesting session for me. I think as we move forward in this space from different disease groups, different treatment modalities, we have so much to contribute to each other. Thank you.
Thank you.
And I think that's it for lunch. So.